to introduce speaker, Vaughan Bell, in a moment, but I just wanted to say a couple of words. This is a new departure for Egenis, and this is our very first Egenis Annual Lecture, so thank you all very much for coming. For those of you who don't know, Egenis is an interdisciplinary research centre that focuses on the study of the life sciences and on all of their ethical, social, and philosophical implications. We are based in a lovely Victorian house over the other side of campus. If you haven't been there before, we have lots of events on every week. And one of the lovely things about Egenis is that I hope that we work on topics that are of interest to lots of people across the humanities and sciences. And we thought it'd be a nice idea to have an annual lecture where we tear ourselves away from our lovely Victorian house and meet up with other people on campus. And we're really, really delighted to have Vaughan Bell here today to talk about a topic that interests lots of us in Egenis, the wider university. So thank you for coming. One of the special features of this being our annual lectures, we will have wine and nibbles, I think. I'm not committing to nibbles. As soon as I said nibbles, I thought, I'm not sure I can hold myself to that. Definitely wine. And non-alcoholic drinks will be served afterwards. So we'll have a pub of drink together afterwards. But for now, I'll just hand over to Sam to introduce our first Egenis Annual Lecture.
Yeah. So it's my great pleasure to introduce Professor Vaughan Bell. He's a professor of clinical psychology and cognitive neuropsychiatry at UCL and a clinician at the Maudsley in South London. He's extremely well published in various academic journals, but also in more sort of public engagement-y venues such as The Atlantic, The Observer, Slate, Wired, The Guardian, Times, Independent, Scientific American, and many, many more. As you can tell from that, probably, he has a voracious intellectual appetite and has interests in psychosis, neuropsychiatric and neurological disorders, and also mental health in the Colombian armed conflict. I've known Vaughan for over 10 years now, and ages. And yeah, it is my great pleasure to welcome him to give this lecture. So take it away, Vaughan.
Thank you, Sam. I think voracious intellectual appetite is just code for not being able to focus on one topic for very long. Apologies for that. Okay, so thank you so much. It's a real pleasure to be here. I'm a Devon boy originally, actually, so it's absolutely lovely to be down in Exeter. And I'm going to talk about why isn't there a philosophy of neurology? The reason I'm interested in this is because I'm interested in the philosophy of psychiatry. And if you know the philosophy of psychiatry, you know it's a massive field. It has its own journals, like the Philosophy of Psychiatry and Psychology. It has its own professional organizations that you can join if you're a philosophy of psychiatry fan. There are many books on the philosophy of psychiatry, loads of them, including one by Sam Wilkinson. And it's genuinely influential. So it shapes psychiatric medicine from the conceptual to the ethical to the practical. So if you ever see a psychiatrist, from the first moment you have contact with a psychiatrist, they'll do something called a mental state examination, which is based on Jasperian phenomenology. Literally shapes the clinical examination that you have. You see with the recent debates about euthanasia and end-of-life care, actually, the philosophy of psychiatry is having a really important influence in how people understand the role of psychiatric disorder in decision-making and what relevance that has in terms of people's capacity to make decisions about ending their life. It's mostly staffed by philosophers and those with crossover expertise, so dual trained in psychiatry and philosophy. So, here philosophers are really kind of having a big impact at all levels of psychiatry, from understanding to practice to policy. And actually, when we think about neurology, there isn't real kind of philosophy of neurology. So let's first just think a little bit about a little outline of exactly what neurology is. So it's a specialty of medicine that studies and treats disorders of the nervous system. i.e. the brain, spinal cord, peripheral nerves and muscles. Traditionally focuses on conditions like epilepsy, brain injury, stroke, Parkinson's disease, autoimmune disorders, peripheral nerve disorders, migraines, and so on.
Could you just talk that way?
Oh, go on.
You'll find over there, it's fine as long as you're facing this way, as in towards.
Oh, really?
It's just when you turn around and look around.
Can I use a microphone?
Yeah, you can do. I think.
That'll probably help, because I need to look
Let's
at the
just check.
slides to remind me what to say.
Check if it's working. It's not working.
Okay. Yes, no, yes.
Yes.
Yeah. Is that working? Yeah. Oh, it is. Blimey. All right, good stuff. So you're not convinced? No, that's probably just the resonance of my own voice. Shall I try with a lip? Or shall I have to side-eye my own slides? I can do that.
That moment there, you were perfect.
Side-eyeing my own slides?
Just, yeah. Half a step forward. Spot it.
Really? All right. I might need someone to do the kind of... Is it the desk mic is the one picking me up?
It's that and these.
Oh, the dangling one.
Yeah, so when you're standing there looking out, you're fine. It's just when you turn.
When you, oh God, this is going to be complicated, isn't it? All right. So what I'm going to do...
Sorry.
I'm going to try. Let's see what happens. Neurologists are physicians, and they do many years of training to become consultant neurologists, and they focus on exactly this. And it's worth saying there has been some interest from philosophers in neurological topics, albeit in a slightly kind of isolated way, but there is good work on selfhood and memory and Alzheimer's disease, the ethics of capacity, consent, and cognitive impairment. But there isn't really such a field as the philosophy of neurology. I was talking to Sam about doing this as a talk, and I was saying, isn't it interesting there's no kind of field? And he typed in philosophy of neurology into Google, and it assumes you've made a mistake. And it goes, did you mean the philosophy of neuroscience? And then shows you all of the results for the philosophy of neuroscience. So it's that kind of like poorly outlined as a field that even Google thinks you're making a mistake when you try and search for it. It does, however, make sporadic appearances. This is the paper that came out a couple of weeks ago. So this is the position paper of the International League Against Epilepsy, and it's an updated classification of epileptic seizures. So the International League Against Epilepsy is a big international organization. They do a whole bunch of stuff. But one of the things they do is they set the diagnostic criteria and classification for different sorts of epilepsy and seizures. Every now and again, they update that. So the last one was in 2017, and this one came out a couple of weeks ago, which kind of conceptualizes and makes some tweaks to the classification of epileptic seizures. And one of the big debates has been about whether we should talk about impaired awareness or impaired consciousness. Originally, the ILAE guidelines said we talk about impaired consciousness, seizures that interrupt your consciousness. And then in the previous ones, they switched to impaired awareness. And now they've just switched back to impaired consciousness. And I was reading this paper that said impaired consciousness is a commonly used medical term broadly implemented in clinical neurology. It's operationally defined by awareness and responsiveness, based on the concept of George Berkeley, William James, and Arthur Schopenhauer. I'm surprised to see Schopenhauer pop up in a kind of diagnostic paper on seizures. It's worth saying that kind of philosophers do pop up in, not uncommonly in kind of neuropsychology and neurology books, but almost always in the same way. There's always a two-page introduction, and it always starts off with something like, brain is the most complex object in the universe. It's deeply mysterious, blah, blah, Descartes, blah, blah, guest philosopher. And then the next 400 pages are all kind of like CT scans and Z-scores. But here, actually, the work of philosophers are actually being used for really practical clinical purposes to help resolve debates about the best way of understanding interruptions to consciousness within seizures to actually make classifications and diagnosis. So it's clearly the case that philosophy is relevant to neurology. It's just interesting that there isn't such a field as the philosophy of neurology. So if we make the assumption that neurology is as conceptually complex as other areas of medicine, more complex than most, I would argue, what would a philosophy of neurology look like? Now, rather than attempting to map out a field, which I think is futile and pointless because fields develop organically and that's the way they should develop, what I'm going to do is suggest some potentially fruitful avenues of areas for which I think philosophy could make a really important impact in some of these key questions in neurology. I'm going to talk about the phenomenology of neurological disorders, ontological status of neurological categories, understanding identity and personality change after neurological damage. So the first one, the phenomenology of neurological disorders. Now, contrary to stereotypes, understanding subjective experience is very important in neurology. And it can be essential for differential diagnosis. So, for example, in the clinic, distinguishing between paresthesia and syncope, fancy term for fainting, or migraine aura and transient ischemic attack, a brief self-resolving type of stroke, will strongly rest on the patient's report of subjective experience. So there may be kind of other tests and things you might do to alter the background probability of either of these things. So if someone has ongoing seizures, it might help you decide that this particular event that they talked about was more likely to be a seizure rather than a syncope. But actually, it is the subjective experience of the patient in terms of the nature of that experience, when it started, how it resolved, its development, which is absolutely key in making these differential diagnoses. Actually, understanding subjective experience is an absolutely core skill in clinical neurology. So we can see that, when we just think about understanding subjective experience, it's a useful clinical skill, but it can also be deeply important in terms of basic research, in terms of understanding some of the core aspects of neurology and neurological disorders to better understand them. And seizures in epilepsy are a prime example. So I'm going to show you some videos of people having seizures. So the first thing to say is, particularly the first one of someone having a tonic-clonic seizure, who feel a little bit strong. Some people, say that they can find it a little bit distressing or a little bit shocking. I'd really encourage you not to think of it in that way. 1% of the population have epilepsy, so this will be a common experience for many. I think the idea that seeing someone having a seizure is kind of shocking or distressing is part of the stigma that accompanies epilepsy. So I've probably just broken your Zoom feed. Second, let me get to my Zoom. Okay, so this is someone having a tonic-clonic seizure. So they just time relate.
It's okay.
Now,
It's okay. You're gonna be okay.
Videos of the seizure on YouTube, reasons of I don't know. Right? Now, probably that is what most people think of when we talk about epilepsy. But actually, epilepsy is a really diverse condition. I'm going to show you someone else having a seizure. And what I want you to do is just have a look and see what you notice.
What's up? What's the matter?
Background rather than something that's complicated. We'll put the focus on person rather than
That was showing in the last lecture.
you want a beautifully lit photograph, just come to the this morning studio. It does. Good light is
You're right, Pete.
So she sort of, as you would expect, bang in the center.
What do you notice there? Very little, right? But if you read his description, he says, during this episode of confusion, I'm experiencing an intense feeling of deja vu, like I have lived this moment forever. I also have an intense feeling of dread, like myself or a family member is about to die, fully conscious at this stage, but not able to respond properly. This lasts for about 3 minutes, and I come back to normal. These come in clusters that can last for about a week. This is someone else who's put some of their partial seizures, so they were called now focal seizures.
God, I'm just trying to remember.
So this is really fascinating, by the way. There's lots of interesting things in epilepsy about the interaction between one's mental experience, one's mental response, and seizure activity. It's kind of interesting when we think about causality in kind of neuroscience and neurology. However, just put everything back on the screen. Slideshow. Yeah. Go, Chris. There we go. So we have these fascinating subjective experiences that occur in epilepsy. So, for example, alterations to the senses, so changes in sensory acuity, hallucinations, the alteration of the perceived relative size of objects, body image distortions, feeling that you've become very small or very big, or the size and shape of your body is changing, changed memory sensations. So the idea that there are specific sensations associated with different memory, such as inappropriate familiarity or inappropriate loss of familiarity. Jamais who is being in a familiar situation and feeling that everything feels unfamiliar. Feeling of sudden clarity of insight, forced thoughts, feelings of meaningfulness or meaninglessness. And of course, there's many more of these. But epileptology has long noted that some seizure-related experiences seem apparently impossible to describe. If you know a little bit about the history of neurology or history of epilepsy, this person, John Hewlins Jackson, will be very well known to you. He was a neurologist, absolutely foundational in terms of our understanding of epilepsy, really influential in shaping the field of neuropsychiatry. And this is one of his lectures from 1879. He says, let me now mention other expressions by the patients as to the dreamy state. Most vaguely it is described as a dreamy state. Often it is said to be a feeling or thought which is indescribable. And actually, this the kind of concept that there are some indescribable feelings that can be triggered by epilepsy is very common. So this was 1879. This was a paper from 2023 where they took a qualitative approach to try and look at the sort of metaphors patients with epilepsy were using to try and describe these indescribable experiences. If you just type indescribable epilepsy into Google Scholar, you'll get a whole slew of papers referencing, case studies of particular patients or particular presentations of epilepsy which have this indescribable feeling which is triggered by certain seizures. So this seems to be absolutely perfect, ripe ground for phenomenology, a discipline of philosophy which is really focused on understanding subjective experience and the structure of subjective experience. And to be clear here, we're talking about what I call big P phenomenology, phenomenological philosophy with the roots in the likes of Husserl and Merleau-Ponty and Jaspers and so on. And the only reason I'm mentioning this is because if you look in the clinical literature, you'll frequently see papers on kind of the phenomenology of migraine or stuff like this. And what that refers to is just what sort of experiences patients tell us about. It's not necessarily a kind of formal philosophical approach trying to understand the kind of basic structure of subjective experience as it is affected and altered by things like epilepsy or migraine. And as far as I know, formal phenomenological methods have only been applied once to seizure phenomenology. This was a study by, French speakers, Petit Menjon, et al. Study on understanding pre-reflective experiences during seizure anticipation. So some people who have epilepsy say they know when a seizure is coming. Now, these may be quite easy or clear experiences like I hear a particular song or I get a particular rising sensation. But some people with epilepsy just say something changes and then I know a seizure is going to happen. And what Petit Menjon did is she worked with people with epilepsy to interview them and try and identify what were these experiences through this kind of micro-phenomenological interviewing to better understand actually what was changing for that person, something that they'd not been reflected on previously and just felt, I know something, it's just a feeling and I know a seizure is going to happen, and went back to try and pick up actually what were the changes in the subjective experience, which were, you know, part of the kind of premonitory experience of epilepsy. And actually, this paper here is a kind of written by a really interesting neurologist up in Sheffield, Alistair Wardrope. It's a clinical paper. It's about kind of understanding the phenomenology of epilepsy, but he does quite a good job of integrating some of these insights from phenomenological philosophy. We can think actually of, you know, what is the potential for phenomenology in applying it to neurology, Binswanger's analysis to understand how seizures disrupt or reveal a fundamental existential structures of human existence. Thomas Fuchs has done loads of really interesting stuff on kind of embodied and enacted phenomenology. He talks about how time is often experienced as kind of bodily state. You think with epilepsy, if you're having seizures which not only interrupt your experience of the world, but can distort time in curious and interesting ways. Some people with seizures go, when the seizure is happening, it feels like I'm living for 1,000 years, for example. So looking at how seizures affect what he calls the temporal synthesis that connects past, present, and future. Lewis Sass is a psychiatrist and phenomenologist who looks at anomalous self-experience, largely applied to psychosis, and talks about that psychosis can involve this disturbance to ipseity, this kind of minimal self where you know that certain experiences belong to you. And this seems like the perfect sort of structure for which you can apply and understand these experiences in neurology, such as in migraine, such as in Parkinson's disease, such as in epilepsy. It sounds like there'll be some fantastic advantages from doing this. A more nuanced understanding of altered experience in neurological disorder, a potential scientific importance. So that this field of neurophenomenology, which has taken this phenomenological approach and tried to match it with consciousness science to pick up slight changes in consciousness as they're identified by the folks doing the neuroscience. It's barely ever been, I think the Petit Mongeon study was the only time it's ever been applied to neurological disorder, despite the fact that a massive amount of our knowledge about the normal functioning of human brain is from looking at people who have particular disorders. It may expand our understanding of human experience. Matthew Ratcliffe's done some really fascinating and interesting work on depression and talks about how understanding how depression affects people reveals that, you know, we might have some certain existential experiences about meaningfulness. Okay, number 2, ontological status of neurological categories. So this is what these categories actually are, what kind of things they refer to, and how or whether they map onto other properties. So the first thing we need to do is overcome a myth, and this pops up a lot, particularly in the mental health world, which is psychiatric categories are based on arbitrary classification of subjective experience, but categories in other medical specialties are based on cut and dry results of objective biological tests. This is like psychiatric exceptionalism, right? Something deeply different about psychiatric diagnosis, whereas the rest of medicine has kind of objective diagnosis based on tests. Actually, foundational, value-laden, and pre-theoretical assumptions are present throughout medicine and its categories. Susan O'Sullivan's recent book is very, very good on this, The Age of Diagnosis, and she, you know, talks about how there's lots of kind of contested types of diagnosis, like Lyme disease, and she talks through how different diagnostic tests work, including those for infectious diseases, noting that actually people think that it either shows you have the disease or don't, and actually relies on lots of background assumptions about the probability of the person being exposed to an infectious agent for them even to be interpreted. Now, obviously, it's possible to do ontological criticism badly to the point where it becomes denialism. But actually, this applies far more widely than you may assume. So if we think back to our rather unfortunate trope of psychiatric diagnosis is fuzzy, but the rest of medicine is all very clear-cut, actually we can see good examples where things which most people would put in the clear-cut bin actually turn out to be far more complex than you think. Simon Chauvin's work is a good example of this. So Simon Chauvin's a neurologist, and he wrote this book, which I've recommended many, many times. It's called The Idea of Epilepsy. Probably one of the great books in the history of medicine is Owsley Temkin's The Falling Sickness, which looks at the history of epilepsy from kind of prehistory to the mid-1800s. And Simon Chauvin decided when he retired as a neurologist and epileptologist to write volume 2, essentially. Now, he's written the history of epilepsy from the kind of mid-1800s to the modern day. It's a monster of a book. It's like 600 pages. But it's really fascinating. And he comes to a really kind of interesting conclusion at the end. So he accepts that there is a practical utility in identifying people liable to have recurrent seizures, but argues that when examined, epilepsy is a diverse collection of neurological phenomena with hugely varying causes that don't easily fit under the conception of a single disease entity. He suggests it's been artificially unified largely due to historical, social, and medical conventions rather than underlying causal presentation. So this is a really good ontological analysis of epilepsy, and regardless of whether you agree or don't agree with Chauvin, he's doing some absolutely fantastic ontological work, tracing it through history, really demonstrating that this sort of analysis is really important in neurology. I'm going to talk about some of our own work we've done here previously, work I've done with Sam on the functional organic distinction. So the functional organic distinction is really central to a lot of medicine, to how diagnostic systems are organized, and to how lots of our healthcare systems are organized. It aims to distinguish symptoms, signs, and syndromes that can be explained by biological changes from those that cannot. So, for example, you may have some kind of discomfort in your bowels. You may go have various tests, and you may be diagnosed as having a particular organic disorder where they find some kind of individually diagnosable biological reason why you're having pain or discomfort, or you may have a diagnosis of a functional digestive problem where all of the tests come out normal and they can't attribute the problems you have to any particular individually diagnosed problem. So this distinction is a key organizing principle in diagnostic systems. If you look at the DSM or the ICD, they have entirely separate sections. They have all of the kind of psychiatric disorders, and basically they have that whole list again replicated as secondary psychiatric disorders, right? So you have depression, and then you have depression attributed to a secondary medical cause. Like you have stroke, you have depression, you have epilepsy, you have depression. The idea is you found an organic basis for that. It's frequently cited as one of the key distinguishing features between psychiatry and neurology. Certainly not the case that each specialism sees exclusively these disorders, although it would be the case that functional disorders are more likely to be seen by psychiatrists and neurologists. And so we became really fascinated by this distinction because it is so deeply influential in terms of how a lot of clinical thinking and clinical services is structured. So we looked at this, and we looked at, went through all of the literature and just did a kind of pragmatist analysis of how functional organic distinction is used in terms of the medical literature, in terms of clinical practice. Well, it turns out the scope of the terms functional organic varies considerably by context. Some things which are functional in some contexts, organic in other contexts, and vice versa. Clinicians don't agree on the meanings of terms and report using them strategically. This also relies on the applied model of zero-sum causality. Right? So if something is more organic, it's less functional, and if it's more functional, it's less organic. Just want you to think about that in terms of kind of medical causality and how realistic you think it is when a lot of our models of medical disorders across medicine very much based on this idea of dynamic interaction of different factors. And of course, the terms have loaded social meanings. If you're used to any of the tensions, the debates, the fights that come up, particularly in kind of neuroscientific medicine, but actually across medicine as a whole, they're frequently about this. They're frequently where a particular patient group often are aggrieved that their particular problems have been identified or conceptualized as functional. And the reason is often because they have quite loaded social meanings. So we know through lots of research, but you'll probably just know yourselves that, if we suggest that something is functional, people perceive that the person's more in control of those problems, that they're more to blame for those problems, that they have more autonomy over them. Where if you have an organic problem, that's literally has a higher prestige. And there's a whole literature on disease prestige. And there's a whole literature on medical specialty prestige. Turns out they link up, right? So the most prestigious specialties work with the most prestigious diseases and so on. So we went on and actually went and did a qualitative study where we interviewed clinicians, 10 physicians, psychiatrists and neurologists, 10 psychologists, clinical psychologists and neurologists working in psychiatry and neurology services to ask them exactly this. How did they understand the meaning and role of the functional organic distinction? So we did a kind of pragmatist analysis of exactly this, and then we took it forward into a study to actually ask clinicians about really their own kind of like pragmatic uses and deployments of this functional organic distinction. The results were really fascinating. So the first one was functional causes were portrayed as invisible and hypothesized through thinking and conversation. And it's usually kind of like the functional aspect which gets the most debate. Right? To what extent can something be a medical problem? If it's functional, is it well placed? It's a problem of living, to what, et cetera, et cetera. I was fascinated by this. That organic factors were considered to be objective, unambiguously identifiable, and clearly causative. So this is a real kind of stereotype of the role of causal factors in medicine. Now, there certainly are some causal factors in medicine which are like that. Actually, the majority are certainly not. Right? So if you think about any common serious sort of disease or disorder, the idea that there'll be a objective, unambiguously identifiable, and clearly causative, kind of organic change, biological change, which will be responsible for the whole of that disorder is that's only a small portion of actually the disorders and diseases we deal with. So we have this kind of real bifurcation, this kind of distinction between these two different sorts of factors, which really don't reflect the complexity of a lot of difficulties and the complexity of the lives people are living. Also highlighted lots of conceptual, contextual factors which are important in their own decisions to deploy the distinction, such as cultural assumptions, service demands, patient needs, colleagues' views, were key to how the distinction was deployed in practice. And most people considered this distinction unsatisfactory, but said that they worked in an environment where their clinical decision-making required it to be used strategically. So in other words, unless I put down excluded functional causes, the patient won't be taken seriously when I refer them on to this particular service. Right? Unless I put down, this seems to be an organic problem, then they won't be accepted to this particular service. And some of these uses included helping communicate medical problems, navigating services, hiding meaning by making psychological explanations more palatable. The stigmatization of psychological explanations seems to be something that people are, really trying to, kind of deal with. Tackling stigma, giving hope, giving access to illness identity. So these are quite amazing, right, in terms of actually what the functional organic distinction claims to be doing, which is distinguishing between different causes, and actually how people are using it in terms of clinical practice. We've got a forthcoming paper on priority research questions on the functional organic distinction, which is a collaboration between clinicians, philosophers, sociologists, and people with lived experience. And really just to try and get people on the same page and trying to cross some of these boundaries to think about, actually, with the functional organic distinction, considering all of these different factors are important, where do we need to go to, what are our future research questions? Is it something to be abandoned? Is it a fiction? Is it a kind of pragmatic tool within the healthcare system? Is it something which identifies causes within medical science? In fact, there are lots of thorny ontological issues in neurology. How should brain injury be defined? This is an ongoing debate, whether it's an event, an outcome, a structural alteration, a process, or a social category. So actually, lots of people in the neurology literature now talk about brain injury being a process. It's a chronic disease which is triggered by an injury and evolves over time. Actually, you can think of it as a social category. I'll give you an example. If I were to kind of ask you, I'm not going to do it, if I were to ask you, put your hands up if you had a brain injury, far fewer of you would put your hands up than I know have actually had a brain injury statistically. Because brain injury includes concussion. There is, in the majority of cases, no brain scan which will identify the changes after concussion. There is nothing you can do to diagnose concussion except ask people if they banged their head and how they were afterwards, unless you observe them. But that is within the range of brain injury. In fact, you can even have a severe brain injury without any alterations on your brain scan. Now, so in other words, when do we identify people socially as someone as having a brain injury? Well, it's not solely to do with the diagnostic. It doesn't match up with the diagnostic process of identifying someone with a brain injury. By the way, there's a big debate at the moment about whether we should call it concussion, whether we should call it mild traumatic brain injury. There's been a big move to stop calling it concussion and start calling it mild traumatic brain injury. Now people are starting to realize actually lots of people who have concussion, stroke, mild traumatic brain injury have lots of ongoing persistent symptoms. And maybe calling it mild traumatic brain injury is encouraging through the nocebo effect some of those symptoms. Better off calling it concussion because people tend to think you recover from concussion and you don't from traumatic brain injury. Two conditions like Tourette's, Parkinson's disease, or impulse control disorders rely on incompatible definitions of involuntariness. So with the tics in Tourette's syndrome, people have often say that they can suppress those tics with conscious effort, a little bit like suppressing a sneeze. And eventually that tension builds up and they feel they have to release that tension. That's quite different from Parkinson's disease. If you have a resting tremor in Parkinson's disease, there's nothing you can't concentrate it or suppress it or make it go away. But obviously, if you moved your hand, because it's a resting tremor, then that tremor would disappear, right? So you could do something which would remove that tremor, which isn't directly trying to suppress it consciously. Impulse control disorders, which can arise in brain injury after treatment with dopaminergic treatments of Parkinson's disease, are things where people end up excessively using pornography or gambling, or sometimes doing something called hobbyism, where they're obsessively focused on their hobbies. Now, there isn't a single motor sequence which is any of these things, but people feel kind of this real kind of inner compulsion to do them. So to what extent are all of these things described as involuntary in the same way, and to what extent does the kind of diagnostic criteria that depend on this actually talk about something similar, and what implications does that have for the category? That final one may seem really mundane, which is fatigue. Fatigue is one of the most mysterious things in neurology. So, the fact that someone can struggle with fatigue after a brain injury is interesting, but be interesting because we really don't know why. And in lots of neurological disorders, fatigue comes up, and there can be a real clear dissociation between physical fatigue and mental fatigue. And we don't really have any explanations for why that happens. It's very common. So should we understand fatigue as a symptom, a sign, a syndrome, or an experience? So there are many such ontological issues which I think philosophers would be very well placed to tackle. And actually could make a really important impact in this area. Okay, finally, understanding identity change, how much of time. Personality change after neurological damage. This is something I've been working on with Sam and Hannah. And this, I have to say, this bit is largely their work. So apologies, you may want to step in and correct me at the various points. Sam, I sent my slides to Sam, which I always do because he kind of whispers, using the word teleological wrong and stuff like this. But I've already corrected a few things in these. Okay. So it arose from work with Headway East London, who are a brain injury support charity in East London, with Sam, Hannah, Hugh Green, I've been Adam Brooks in Cambridge, me and several doctoral trainees who are younger and brighter than me, as they normally are. And personality change is fascinating after brain injury, because sometimes people's personality changes in a way that they say, well, something has changed, but we can't quite say exactly what it is. but that can still be really difficult for them and their families. It's sometimes described by families as they're no longer the same person, and at its most striking, it can result in a diagnosis of secondary personality disorder, which is a kind of psychiatric category that identifies that the personality has been changed in a way which is really dysfunctional, in other words, impairing or disabling. So in 2008, Yates et al. Made an amendment to this proposal. They said that we should completely disregard and chuck out the idea of personality changes after brain injury, because they said personality isn't a neurological category. There's no direct damage to personality alteration link. But actually, personality change is probably multifactorial, and there are aspects to do with psychosocial, such as coping mechanisms, self-representation, and social factors like family dynamics and communication, all of which bear on someone's personality and their likelihood of being labelled as having personality changes. They said that judgment has consequences in itself, may become part of the process. If we identify someone as having a changed personality, they may react against or in line with that. And it may relabel and misdirect us from psychological distress in both survivors and families. In other words, they cite some studies which show that a predictor of someone being identified as having personality change is psychological distress in the families and in the person, and they described it as a clinical dead end. So this is something that a paper recently submitted tackled, and kind of we argued that actually it does make sense to talk about personality change for a number of reasons. The first is that personality is common cultural currency, so it's intuitively appealing, but it also plays an important role in social interaction. It's an overall evaluation of complex but stable socio-behavioral traits, so we can understand personality in pragmatic terms rather than essentialist terms, right? We don't need to have a neurological category of personality to make sense of people's claims that this person's personality has changed after having a brain injury. However, it is important to bear in mind that personality itself is a value-laden construct. I don't know which of you wrote this, but it was far better than I could write. To say that someone's personality has changed is not simply to describe them, but to evaluate them, to signal some change in them as a source of value to you. And indeed, personality, even the kind of objective, so-called objective personality science and personality psychology, has lots of interesting factors. So you can see that something like openness to experience probably doesn't seem quite as value-laden as agreeableness. So there are certain factors of personality which do seem to be quite value-laden. There's a really interesting study of people with frontal temporal dementia, which showed that it was particularly changes in these morally and value-laden qualities which are most likely to lead people to be identified as having personality change. Right? Your openness to experience alters. People are more likely to say, oh, it's the same person, they're just not as interested in stuff. But if your agreeableness changes, and people go, oh, they've had a personality change. So it's important to note that judgments of personality will be subject to variations in social perspective and will be subject to changes at the neural, psychological, and social levels and evolve over time. One of the things that I find really interesting is that, this idea of hard to describe personality changes and the fact that some of them are not considered to be clinically relevant. So when you look at some of the diagnostic criteria for personality changes and personality disorder, there's this idea that the clinician has to identify the personality change as clinically relevant. So what would count as a clinically relevant personality change? Well, it's kind of a fascinating question, right? It does bear heavily on the kind of assumptions and models of personality and also the values of clinicians. There's lots of interesting evidence that actually people do some interesting stuff as clinicians, right? So people try and make brain-based ascriptions for behavior to maintain a good person model of the person with brain injury, right? So someone with brain injury is aggressive or rude, and that is explained as their brain injury. Right? And this seems to be a kind of like compassionate move on one level, right? Which is, we want to maintain this idea of this person as a good person for which their brain injury has impinged upon their good nature, and therefore anything they do which is challenging shouldn't challenge our idea of that as a good person, which I thought made a lot of sense to me. And then we talked to the folks at Headaway East London, survivors of brain injury, and they went, yeah, but you do realise that is used to dismiss a lot of our concerns, and a lot of our complaints, right? This is your brain injury talking, it's not you. So there are these kind of interesting, kind of explanatory and cultural and social forces which bear on exactly this problem. And there are many related issues which I think philosophical approach could be really useful. So what are the necessary and sufficient conditions for personal identity across radical personality changes? If someone's values, preferences, or emotional responses have changed, but they are cognitively intact, do they have the capacity to make decisions? How should legal and moral responsibility be assigned when personality changes leads to actions that the earlier self would not have condoned? And you can see that these are clearly not solely scientific issues for which evidence from neuropsychology and brain scans will bear. These are really key issues for which the experts will be philosophers or sociologists. So you may notice that I turned up with the title of the talk, which raised the question that I haven't actually answered. Because actually the main kind of thinking behind my talk was less to answer this question, but more to try and interest people in philosophy as a neurology, as a focus for kind of philosophical inquiry. But we can think, why isn't there a philosophy of neurology? So perhaps because it's wrongly perceived by outsiders as being about physiology, when in fact it's a deeply human discipline, doesn't have a headline cliche that acts as academic clickbait. So, with the philosophy of psychiatry, what is mental illness? Actually, a lot of philosophy of psychiatry is not particularly concerned with that. It is a valid and important thing for the philosophy of psychiatry to investigate. I'm not suggesting this is not an important or useful question, but this is the thing which is kind of the banner of philosophy of psychiatry, and the philosophy of neurology, if it were a field, doesn't really have something similar. And there's less philosophy taught as part of modern neurology training, so perhaps less crossover interest, and perhaps wrongly assuming that it's all just philosophy of medicine. There's nothing particular about neurology which requires any particular focus or engagement with the specifics. I think probably the main reason why there isn't a philosophy of neurology is because not enough people have started. So I'm here talking to a lot of philosophers, or philosophers. Yoshi asked me earlier, are you a philosopher? I said, I'm a fan of philosophy. So, and just because I found it so important in terms of clinical work, in terms of my research, in terms of actually some really important understandings and advances it's made to make sense of psychiatry and neurology. So the reason, if there's not enough people who started one, I'm going to encourage you, if you're not going to start the field, at least consider it as something important and something you encourage other people to take seriously. Thank you very much.